So for this week's schedule, just to give you a heads up, as you can see, we do not have any pictures, so there's no new pictures for today. There's also no clinical, or I should say medical terminology. I didn't get a chance to type it up. So there's no medical terminology this week. However, we still have to just finish up with chapter 14 because we didn't have a chance to get to that chapter last week. So we're going to continue with chapter 14, so you will be responsible for the pictures for that particular chapter, okay? Which you have in your picture sheet from last week. And then also, today I will add in lab values for those cardiovascular diseases, so you do have lab values. Today's material is quite a lot, so, which, to give you a heads up, we will not be able to get through 19 and 20, so even though you guys picked up those PowerPoints, just hold on to those PowerPoints for the following week that we need, and we'll be able to catch it up from there, okay? But I'd rather take my time and go through the information, even though our schedule on the syllabus is crazy with all those chapters. But I'd rather take my time and go through the information, make sure you understand it, than to just kind of rush through and breeze through it. And so we'll work it out. We'll get to the finish line. Yes, I'm sorry, she had a hand.
Are we going to go over the lymphomas from last week? We didn't.
No, lymphomas, remember I'm adding to your topic list for your presentation. So I have to update your topic list with lymphomas and also congenital heart defects and a few other things. Yeah.
So I just got a little bit of clarifying. So next week is Thanksgiving, so we're not doing the class, and then the following Thursday, that's going to be our midterm?
Yes, and I still have to lecture that day too.
Okay.
So we're going to lecture on the chapters. I'm going to send an email because I'm still trying to get this together because your class is the Thanksgiving day. So we're definitely going to do 19 and 20, which you guys already have the PowerPoints for. And then I do have to add in respiratory. Yes?
Sorry, so just to clarify, 19 and 20 aren't midterm?
No.
Okay.
Okay, so let's get started with 14. 14 was some information that I gave you guys last week, and so you do have to pick back up with this particular chapter. This chapter is titled Alteration in Hemostasis and Blood Coagulation. Just to give you the definition of hemostasis, if we had a medical term list, I probably, actually we did have this on the medical term list. So hemostasis, you guys know, is the arrest of bleeding or the process to stop blood when a vessel is injured or when the vessel is broken. Okay, so this is what goes on. When the vessel is broken, when we try to stop blood or when the body goes through the process of stopping blood to prepare itself or repair itself for that injury. Now, we're going to talk about in this chapter alterations that happen, meaning that people that have issues with bleeding, and not only just bleeding disorders, but sometimes bleeding issues can be acquired from other things. The first couple of slides with this chapter, you guys do not have, and those first couple of slides actually covers the normal physiology of blood coagulation. Now, I don't know if you guys remember this from physiology, but what is important when we clot the blood? What is needed? What are some things needed to clot the blood?
Platelets.
Platelets, definitely. What else do we need along with platelets? Or that's also kind of part of that process. Very good. Coagulation factors. Understand that coagulation factors, although there's many and they all have a different function, but the main goal of coagulation factors are really to attract more platelets to the site of injury. Okay, so they can continue building up that platelet wall and that plug. Okay. Don't forget that there's also part of that coagulation factors an ion called calcium. Calcium is needed and it is important to have an adequate amount of calcium to also help for binding purposes of those factors, okay, so they can do what they need to do. Calcium is also needed for coagulation. And another thing too, when you have a vessel that's broken, understand that the vessel will always first go into a vasoconstriction, okay, even before the platelets come. And it's almost like the body's sort of compensatory mechanism. So say, for example, if you touch a hot stove and you put your finger there, you don't leave your finger there so you can burn. You actually will draw back And so it's kind of the same thing. As soon as the injury happens, the body's way of responding to that is to draw in, okay, to try to stop the blood even before the platelets get to that site, okay? So understand that the vessel wall will undergo a constriction also to help with that. So just keep in mind, and if you guys need to refresh those things, I would say in your book, just kind of go through the first part of that chapter if you need to refresh blood coagulation. Now, your PowerPoint starts here. Okay, so we're going to get right into the evaluation of coagulation. Why would we do this? Why would we evaluate patients with this situation? And also go into the disorders. So evaluation of hemostasis and coagulation, this is included most times in a patient's history and physical. It is to determine if a person has an underlying bleeding disorder. So sometimes people don't know they have a bleeding disorder, or even not just the disorder itself, or maybe they have an acquired type of bleeding issue, okay, from maybe their medication or whatever. Now, why would we do this? There are a number of reasons why you would do an evaluation to check to see if a person will bleed out. Number one, if a person does know if they have a family history or if they know they have a history of a bleeding disorder. Sometimes people know that they do have this in their family, and so it is best for them to have an evaluation done periodically to just make sure that their levels are up to par. Another thing, during active bleeding, that is unresponsive to standard intervention. So I'll give you an example. A couple of terms ago, well actually, I want to say like 2 years ago, when I used to teach anatomy, if you guys took anatomy here, you remember you had bone cutters to do the spinal cord dissection? Okay, for those of you who took anatomy here, well, I'm kind of the reason why you have bone cutters. So what happened was there was a student, before bone cutters, we actually had scalpels. And we were using the scalpels to cut bone. And we know the scalpels are flimsy. Well, we had someone that sliced their finger really bad. And he was a bleeder. Okay, the nursing instructor came in and everyone tried to, and so we did all the proper first aid, but he was still bleeding beyond the normal bleeding time. Okay, now, if someone goes past the normal bleeding time, okay, and I'll give you the normal bleeding time in a little bit, but what do you think could be some issues if a person just continues to bleed and it is not stopping? What do you think could be some possible issues? Yes, they're losing too much blood and definitely can lead to loss of red blood cells. What else? Well, what could be the cause, I should say, of why they're bleeding out?
It could be like they have a low amount of calcium in the blood.
Very good. It could be a low amount of calcium in the blood. Okay, so sometimes we don't think that these electrolytes or ions are very important. We do need them for a lot of different functions in our bodies. Very good. What else? What else could be an issue why this person is just bleeding and they're not stopping? Thrombocytopenia, very good. So if this person does not have enough platelets, that's getting into that area. What else? What are some other things that you think could cause a person to bleed a little too much?
Taking a blood thinner.
Very good. People that are also on anticoagulant therapy, such as Coumadin and blood thinners like that. Keep in mind when patients are on that type of treatment, which is also on here, anticoagulant therapy, when patients are on those types of medications, they really have to be monitored because sometimes the levels, if they're not in the proper amount, they can cause the blood to actually thin out and cause them to actually have more bleeding episodes, okay, which is the adverse reaction that we want. What about some other things that you think can cause a person to kind of bleed a little bit extra? Think of some other conditions or issues that may be going on with the body. Don't forget liver issues or liver disease. The liver makes coagulation factors. I think we talked about this week 1. So if a person has liver disease, is it a possibility that they may have issues bleeding? Yes. Also, don't forget cancer patients, which we talked about with the bone marrow suppression, which, yes, as you said, thrombocytopenia. And also, believe it or not, alcohol ingestion. Sometimes with people, too much alcohol ingestion can cause the blood to thin out, and when there's an injury type situation, they can have excessive bleeding because of that.
And would that be like chronic overuse of alcohol or just like at that moment?
Chronic overuse of alcohol. Chronic overuse of alcohol. Okay, so just understand some things that can happen if a person's bleeding out too much and if it's not responsive to like a standard first aid and things like that. If you can't control the bleeding, then we would think of some other things that can be part of or an issue why they're bleeding. Even sometimes patients may not know if they have a history of bleeding disorders, okay? And so they may not find out until that very moment. Screening before surgery, that is a big check mark there. Why? Because we would never want anyone going under the knife not knowing if they have a bleeding disorder. Okay, so you definitely want to check that out before they go into surgery, and that is definitely one of the major things that's done with pre-operative testing or pre-admission testing. They have to do a blood coagulation assessment. Okay, and then we already talked about anticoagulant therapy. Okay, so this table here kind of gives you a little bit of clues as to what can happen as far as the type of bleeding that you'll see in individuals and what possible disorder it can be linked to. So family history of bleeding in both males and females, they say that this is most commonly with von Willebrand's disease. Von Willebrand's disease is a hereditary bleeding disorder. And so this is a hereditary bleeding disorder that is common in both males and females. Then if a person has a family history of bleeding only in males, and with only males, we know that this is most commonly linked to hemophilia. Both hemophilia A or B. Okay, so there's two types. And we're going to go over each disorder in detail. Newly acquired bruising. So we talked about bruising a little bit, I'm going to say last week. With bruising on the skin, keep in mind if it's not, say, an elderly patient and we know that they can have thin blood vessels and start to have bruising, but a person that's not in that situation, keep in mind that most bleeding actually comes from patients that take too much aspirin, ibuprofen, and medications that do cause excess bleeding. Make sure you know that because clinically, when we think of bleeding disorders, most of the times people think of it's always going to be like a hereditary bleeding disorder. That's not always the case. The most common bleeding that you're going to see are patients taking too much aspirin, too much ibuprofen. Maybe even, believe it or not, some antibiotics have a side effect of bleeding, so it's going to be medications that actually make them bleed out too much, even the anticoagulant therapy. If that's not controlled, that will cause excess bleeding. Bleeding disorders are actually kind of rare compared to that type of bleeding that you'll see. Okay. Now, excessive bleeding and bruising during and after surgery sometimes can be from if a patient really has a deficiency in coagulation factors and or von Willebrand's disease, a hereditary disorder, with some drugs. And then bleeding following initial hemostasis. So sometimes patients will have bleeding after they start to clot. Okay, that can be from a factor 13 deficiency. However, there are also some bleeding that can occur from different conditions. There's a condition called DIC where a patient actually will clot and hemorrhage at the same time. I know that sounds strange, but it's a deficiency where the body actually hemorrhages. And if as fast as the body's going to hemorrhage, that's as fast as it's going to clot. And so that poses a lot of issues. But we're going to go over that in detail in a second. Okay. So for personal assessment, for clinical assessment we have here, we already talked about family history, history of bleeding. Systemic diseases that may be involved. So as I told you before, liver disease. Liver disease is definitely one of those things that you want to kind of keep in your mind if a patient checks off, like on an intake form, that they have a liver disease. Because if they have liver issues, that means that it's a big possibility they're not going to make enough coagulation factors to clot the blood. Another thing too, cancers. So cancers, we already know what's going to happen there. This is going to lead to a possible bone marrow suppression. In medication history, we already talked about, yes, definitely aspirin, NSAIDs, but even, believe it or not, what can go on this list, they do say some antibiotics can also have a side effect of bleeding. So it just depends on the type. Now, let's go over some of the physical findings. Last week with your image sheet, there were some pictures that we didn't get a chance to go over, so we can go over these pictures now. The first picture that you have, and I want to say it's maybe on the third page, is petechia. Petechia, when you look at this, these are little red pinpoint dots on the skin, and that represents bleeding, okay, bleeding under the skin. Oh, before I continue, just let me, I just want to say, when you want to assess a person for bleeding, you have to look for anything that's skin and mucous membranes. So obviously, if you're not seeing the blood pouring out from the actual injury, the only way you can really physically see bleeding is on the skin and mucous membranes. Okay, so whether you're looking at the skin, maybe around the mouth, even like the sclera of the eyes, then that way you can tell like certain hemorrhages that occurred. Other than that, if it's internal bleeding, you will not be able to physically see that, or physically see it, but just kind of be able to assess from the signs and symptoms that come from internal bleeding. Okay. So, to continue on, purpura. Purpura is what is called patches or clusters of petechia. So if you look at the picture with the child's leg, it kind of looks like a rash. That's actually bleeding. It's the same thing as petechia, but it's just more in a cluster formation. It's cold, right? Ecchymosis. Ecchymosis, this is what we call a flat bruise. A flat bruise. So when you look at that bruise, it just kind of looks like as if, and that bruise actually can be from an injury, so it doesn't always have to be, from a coagulation disorder. That can be from an injury, maybe even from a cancer situation. So what happens here, it will also go into the different stages of coloration. So as we know, when we bruise and have injuries, it'll go from the different colors like black and blue and red, and so all the different stages. The next one, if you turn the page, we have hematoma. And hematoma is what we call a raised bruise. This is a raised bruise. And again, this can be from a coagulation disorder or even an injury. And with this raised bruise, what happens is it will actually cause the epithelium to elevate because of the amount of blood and fluid that builds up. Okay, so it's blood and fluid that builds up. And the fluid is from the inflammation, the inflammatory process. And in an injury situation, that happens pretty quickly. I remember seeing this happen to a child running, fell face down on the concrete. And as soon as he got up, I want to say maybe in less than a minute or two, that hematoma came up on his head, and just like that. So keep in mind, in an injury situation, they do occur pretty quickly.
Are these bad?
No, they're not bad unless it starts compressing on an organ. So in that situation, that's kind of more like a superficial sort of hematoma. So that, with first aid care and everything, it should go down after a while. But if you have a hematoma that may start pressing on a nerve or, another type of tissue or organ, then that would be an issue. Okay, now hemarthrosis. Hemarthrosis, as you can see in that picture, this is actually, hemarthrosis stands for fluid in the joint, blood in the joint. So this is blood in the joint, in the joint space. And looking at that child's arm, that blood actually pulls up, and it actually just kind of looks like fluid or edema. However, that is blood. Okay, and so even if fluid, or if there's like, say for example, you would think a hematoma would be there. That's red, but don't be confused. I don't want you to think that hemarthrosis is always going to appear red around the joint, because redness around the joint can also just be regular inflammation. But in this situation, this is blood. Okay, that's blood in the joint. Now, Hemarthrosis is also very common, and if you want to jot this down now, it is a hallmark for hemophilia. So hemarthrosis is a hallmark for hemophilia. In hemarthrosis, just looking again at that picture, that can be from hemophilia, believe it or not. That can also be maybe from a fracture. That could be from a child, let's say if the child had osteosarcoma, a bone cancer, okay? So that can be from a number of things. And then the very last one that you guys have here, the picture, is called telangiectasia. Get that out, but telangiectasia. This is bleeding under the skin that actually has this sort of spider web appearance to it. It looks like spider veins, but it's not. It's actually bleeding under the skin that comes with these kind of strips or striations under the skin. This particular presentation is common in patients that have liver disease. This particular one is common in patients that have liver disease. Okay, but you can see it in other bleeding conditions as well. And then we already went over occult and frank blood. So for laboratory testing, CBC obviously will be done for anything. And with the CBC, we want to look for a red blood cell count to determine if this patient is having anemia. If the red blood cell count is low, that's telling us that they are having bleeding. Okay, maybe some bleeding that you can visibly see or bleeding that you cannot see. Okay. Platelet count. Platelet count will obviously identify the number of platelets that a person may have, okay, to let us know if they can clot the blood. And also a peripheral smear of the platelets. So I know this sounds a little strange, but if you remember from anatomy, platelets are actually just like, what do they call it, like a little strip or like a fragment, almost like of a cell. So they really don't have a very distinct shape or a nice circular shape like other cells. However, they all do have sort of a uniform look to them. So if you do a peripheral smear and able to look at platelets, they should all look uniform. Now, if they don't look uniform, just like when we talked about leukemias, that tells us that this particular platelet is non-functional. And believe it or not, some people sometimes do have non-functional platelets. And that is also considered a disorder, which we're going to go over in a little bit. So that's important. Another thing that's important too to test is what is called bleeding time. Bleeding time, as I was telling you before with the story of the guy that cut his finger, bleeding time is actually between 3 to 10 minutes. So if you want to jot that down, bleeding time should be somewhere between 3 to 10 minutes. And some books say 9.5, so 3 to 9.5 or 3 to 10 minutes.
Yeah.
So which means
And that's normal bleeding?
normal bleeding time. So which means when you injure yourself, okay, for example, if you cut your finger or whatever, and you're bleeding, you should stop bleeding within 10 minutes. Within that time frame, all your coagulation factors, your platelets, calcium, everything should come and do its job to stop that blood, okay? If you start bleeding or if you continue bleeding beyond 10 minutes, then there's not enough of something, okay? That's not happening. So that's bleeding time. Now, the next two lines here covers some other testing that can be done, which is part of what is called a blood clotting assessment. It is in your clinical reference guide, however, I'm not going to have you memorize that particular lab value, but I will go over just to explain what it is. So let me just give you the full name for these abbreviations. So PT stands for prothrombin time. PT stands for prothrombin time. PT stands for prothrombin time. INR stands for International Normalized Ratio. International Normalized Ratio. And then let me go over this one and then I'll go back and explain the whole thing. International Normalized Ratio. And then APTT, now sometimes, and depending on which lab sheet you're looking at, sometimes they'll have it as an A in front and sometimes they'll just have it as PTT. So it just depends, but it's still the same thing, whether it's with the A or without. So A stands for activated. The P stands for partial. Partial. T, thromboblastin. Thromboblastin. And the last T for time. So activated, partial, thromboblastin, time. Okay, so what's the whole point of this? These set of tests are done and they're grouped together as what we call a blood coagulation assessment. Okay, and it is on your clinical reference guide. You can take a look at it at home. You don't have to memorize it, like I said, for our test. However, I just want to show you what it does. Now, you don't have this slide, but it's okay. This should be familiar to you, hopefully, from physiology. So in physiology, you guys should have gone over the blood coagulation cascade. This is the full blood coagulation cascade. Most of the time, students don't remember the entire thing, but they usually remember the last portion, like the prothrombin, the thrombin, fibrinogen, the fibrin. Does that sound familiar? So usually people remember that step, but this is the entire cascade. And so it goes over all the factors that are secreted and what happens to bring those platelets to the area and make that fibrin to cover it, that mesh, to make a full clot. Now, when that blood clotting assessment is done, the PT, INR, APTT, that assess the entire coagulation cascade. So those tests tell us, okay, that this person has undergone every factor that they need to make sure they clot the blood. And to be exact, and they have this chart in your book if you want to take a look at it at home. And to be exact, each part of that test assesses a different part of the pathway. So PTT assessed the intrinsic portion, the PT assessed the extrinsic, and the INR assessed the common pathway. So what's the point in that? The point in that is if one of those tests are off, it gives us a clue as to what factor could be involved, so that you know which factor could be an issue. So again, I'm not going to test you on that, but I just want you to have an idea when you do see blood clotting assessment tests, what it's used for. Okay. All right. So let's get right into the disorders. So we're going to go into vascular and platelet disorders. Okay, so all of these disorders that we're going to go over can be in a group of what is called acquired or inherited. Okay, so when we talk about something being acquired, something that develops over time, whether it's from medication or whether it's from a person with alcohol abuse or maybe some sort of disease process that's going on with that person. So acquired. Inherited, we all know that's family history. Now, the first one we're going to cover is what is called vascular purpura. So purpura, we already took a look at the picture. We know what it looks like. Okay, the patches of petechiae. We do have different types of purpura, or I should say different ways purpura can develop. Okay, so they really should kind of have this listed like 1, 2, 3, 4, 5, but it doesn't matter. We'll go over each different type. So the first type of purpura they have listed here is something called allergic purpura. And they say that this is an autoimmune process. So what happens here, unfortunately, your body can attack your vessels and break it down. So this is where the body attacks the vessels and break it down, making it obviously thin to where this person will start to bleed. It is an autoimmune process. Okay, so this is allergic purpura. Ehlers-Danlos syndrome. This is an inherited disorder, if you want to add that in. This is an inherited disorder. And this is where patients are born with not enough collagen and elastin. So they're not born with enough collagen and elastin. So if they're not born with enough collagen, obviously this will make the blood vessels very thin. However, what else is going to be an issue if you're not born with enough collagen?
The skin?
The skin, very good. And blood vessels, yes, which gives them the purpura. But what other body parts that collagen is used for? Don't forget our ligaments and tendons. So these patients will have very brittle joints, or not brittle, but very, a lot of issues with their joints. There is a disease called osteogenesis imperfecta. I don't know if you guys have heard of it, but this particular disorder is very similar because these patients do also lack collagen. And these patients are very, very fragile. Okay, their joints are very fragile because they don't have the collagen to support the tissues to support the bones. Also, they have sometimes heart issues. Sometimes they'll have issues with the skin, blood vessels, all of those things because of the lack of collagen. Okay. Vitamin C deficiency. This is considered to be acquired. Okay, so this falls under the category as acquired, vitamin C deficiency. So vitamin C deficiency, most likely from nutrition. Okay, vitamin C is extremely important in making collagen. Okay, and some of the women may know that because sometimes in some creams and even like certain facials, there'll be vitamin C facials to enhance or enhance collagen synthesis in the skin. They also have vitamin C injections, okay, to also enhance collagen synthesis. So keep in mind, they have a lot of things with anti-aging surrounding vitamin C, okay, because they want to enhance collagen synthesis in that individual. Because we do lose it as we get older. So that's one big thing that they use in cosmetics. So, aging. Aging is another thing that we know is just part of the process as everything goes south. And we do lose that collagen, and we also lose that collagen and lose part of our connective tissue as well. Okay, so with vascular purpura, again, we already know what it looks like, but they do have a particular test for it. This test, to me, sounds very invasive, but I'll go over it with you. But one of the students, I want to say, I think she was in yesterday's class, she said that one of her patients with I forgot what type of patient she was treating. But anyway, when the patients have purpura, she said even if they just do a regular blood pressure test, they can see the purpura pop up, okay, on the arm. So let me explain how this is done. It's something called a tourniquet test. So when the blood pressure cuff is placed on the arm, they will pump it up, and they actually hold it for 5 minutes right at the systolic and diastolic mark. Now, if you hold the blood pressure cuff for that length of time, or let's just say just hold it there, right at the systolic and diastolic mark, what are you doing to the vessels, or what's happening to the vessels right at that moment? It is very constricted, as well as, what about the blood? It's filled with as much blood as it can possibly have in there, and constricted at the same time if you're holding it right at that mark, okay? Now, what they do is, the point of doing this test is with this, holding it for that length of time, if those vessels are weak, because it's so constricted and it's filled with so much blood, if they're weak, they are going to burst. Okay, and I know that sounds mean to do that, but they have to test to see the vascular status of that blood vessel. So if they break, what will happen is the patient will start to have a presence of purpura that will pop up in the antecubital space. Okay, and like I said, I was told that you don't even have to hold it for 5 minutes. It will still just pop up like that when you just do a regular blood pressure assessment. Now, for treatment,